Hello, everyone. Can you hear me okay?
Yes.
Yep.
Yes.
Thank
Yes.
you. Great. Thank you. We are going to go on ahead and get started. It's 2 o'clock. I'm Dr. Tina Lewandowski, and I'm the Director of Engagement. I would like to thank everyone for attending. Today, we have Michelle Niedens here with us to present, and the title of her presentation is "It Takes a Village: Empowering Families and Communities in the Cognitive Care Network." Michelle is the director of the Cognitive Care Network, otherwise known as the CCN, at the KU Alzheimer's Disease Research Center. The CCN is a community-based integral health project that helps patients and families better understand and care for those experiencing cognitive changes by offering a variety of resources despite location barriers. With over 20 years of teaching social work practice and 12 years in geriatric, psychiatric acute settings, she's an expert in her field. Michelle will discuss the CCN program she has implemented from the ground up and the incredible reach it has had on impacting the lives of those in need. It's just a friendly reminder, please keep your microphones on mute, and if you have any questions during the presentation, you may type them in the chat. We'll have plenty of time for questions at the end of the presentation, and Michelle can answer them at that time. As always, we'll have the recording available within 24 hours as well. So, Michelle, I will go on ahead and turn it over to you.
Yes, thank you. Thank you. And I will say, you know, after so many years in practice, this is 38 now that have had the opportunity to work with people with cognitive changes, that we see various things and have lots of opinions in terms of what we see in the state of support and care. And I also want to say that we have seen changes. We hear so much about, as is so exciting to hear about, all the advances on the science side. And I will tell you, there's lots of advances going on the service side as well. And so we're going to talk about one approach that we use at KU and talk a little bit more about that. This concept of absolutely it takes a village, absolutely that we need to shift and expand point of support and care. So we developed the Cognitive Care Network. It's been about 4 years now in play, and there were some really specific reasons why we thought developing such a network was important. And part of that was the awareness that people are being diagnosed too late into the disease. And not too late in that there isn't anything that can be done, but too late in that they had experienced undue stress and challenges because we had not approached early. That there might have been ways we could make things a bit easier, not easy, but a bit easier for families and individuals diagnosed. Perhaps the trajectory of their experience and acceptance might have gone differently if we could have detected early and implemented a more holistic approach. So what we see by and large in present day is that mild cognitive impairment or early Alzheimer's disease is often missed, and there's some specific reasons for that. Less than half of individuals indicate that they have been told by physicians that diagnosed them that they had a dementia, and if they're diagnosed with a dementia, what type. And you know, it's not just on the healthcare side. Only 45% of individuals with subjective cognitive decline even brought their concerns to a healthcare professional. So part of it is on the healthcare side, recognizing those subtle early signs. Part of it is us as a community recognizing that these cognitive changes are not normal. It doesn't necessarily mean Alzheimer's, doesn't necessarily mean a dementia, could be depression, could be some other health issue, could be, you know, an acute medical issue, resolvable medical issue. But, you know, when we began to see these changes, we need to bring them up. The most common screening tool used in primary care is something called the mini mental status exam, which has very low early stage sensitivity, around 24%. So when the MMSE is used as a screening tool, we miss it about 76% of the time. And we have made, again, lots of advances on the service side. One of those advances a few years ago, I think maybe 5, Medicare ruled that as part of the Medicare wellness annual checkup, that there needed to be a cognitive assessment. They did not dictate what type of cognitive assessment. So again, most providers are still using the MMSE. Some are just saying, are you having any problems? And the answer is no. But at least that's in place. Unfortunately, about 16% of Medicare recipients indicate they've received a cognitive assessment. So whether that has been skipped or whether it has been so subtle that they didn't understand that's what it was, but at any rate, not thorough enough or not vested enough that we were really assessing cognitive changes. And this next one is really, really important. You know, we don't have the guns. If it's something like Alzheimer's disease, if it's something like Lewy body dementia, if it's something like FTD, we don't have the weapons right now to cure. We don't. We don't have the weapons right now to halt. And if we just stay there and because of that fact, we don't take any other steps, we have failed a whole bunch of people. And so our goal really is on functional preservation. We acknowledge at this point, although that's changing, you are on these weekly webinars, you know there's lots of amazing stuff going on in science. And I'm thrilled about all that. I'm also vested in, even today, our goal is preserving functional status. It is important to me that people stay as well as they can, as long as they can, as independently as they can. Very important. And we do have tools, we do have weapons that can support that. So about 70% of individuals diagnosed in early stage and their care partners do not engage in education and support services. So again, we're talking about, we're not, there's no, one target, so to speak. It is systemic that we all have to be vested in early detection. And this looks at just a survey we did a few years ago that substantiates the commonness of the MMSE. This slide simply looks at research examining care partners and individuals diagnosed and their likelihood of using services. So the most likely individuals that would, if the doctor said, hey, I want you to go to this education program, I want you to sign up for this program, I want you to consider research, I want you to reach out to a support group. So the most common users of services on the caregiver side are those that are more educated, and I would say more educated in healthcare. So people that are nurses, doctors, or have families that are, and that have a greater level of burden. And individuals with the disease that accept services are those are more likely to accept services are those with greater cognitive and functional impairments that have mood issues that have transitioned into behavioral concerns and that have had diminished activities due to the cognitive changes. The non-users were individuals that were less depressed, who had more social supports, who had less direct cognitive and functional implications, who were not experiencing mood issues that implicated behavior. And you know what that means? You know what all that means? That means the people that are not using services are people in early stage. That's what that means. That we wait until there's a crisis before we decide that we want to accept help or services. That's what that means. So again, systemically, we've got to think about this differently. We cannot think about this as, gosh, it's a default. And if I have to use services, if I have to get some support, if I have to learn, that I'm going to wait till the last possible moment because it means something terrible. Rather, we need to think about it a whole nother way and say, we're going to get on the front line of this. We are going to become active, proactive in addressing concerns and living the best life we can. So the cognitive care network is really about shifting some of that. So we have a partnership with primary care providers in our region. We are at about 81 providers at this point in a multitude of counties, and we train those primary care docs on early detection. They go through a education program and agree to be part of the CCN, and in doing so, they work up those cases and they refer to a social work navigator at point of diagnosis instead of point of crisis. So we're moving what is currently a crisis-driven model of support to an empowerment model of support. We're going to talk some more about that. And our goal really is to extend function, to prevent neuropsych crisis, to prevent some of the worst of caregiver burden, and to decrease avoidable healthcare costs. And really doing that through the introduction of support services. Now, this wasn't just our idea, and it isn't just Michelle's opinion or someone's opinion that this is effective. There have been similar programs that incorporated an interdisciplinary team that showed tremendously positive results, some of the same that we see in the CCN. So improve physical, emotional, and mental well-being for people with dementia care partners. That does not mean absence of distress. That does not mean absence of grief, but that we're talking about how we navigate it and how we accept and move and be prepared. Improved identification and diagnosis of dementia. Our project has really worked at the early detection, which is relatively novel, at least as we see in the research and through the network that we talk to. Improved anticipation of deterioration and care coordination at end of life. So people are prepared and that their decisions are not accidental or born from being overwhelmed or grief-stricken. Reduced and delayed transitions into residential and nursing care. Amazing that when you incorporate help earlier, when you, what I call wage the battle earlier, you actually are able to maintain at home and be more independent longer. And then it reduced inappropriate hospital admissions, both from an acute standpoint and from a psychiatric standpoint. And finally, improved communication between services, which can be very much be a challenge in this world of compartmentalized specialties. So this is where we are. This is common detection practices now. As we talked about, most typically identified through complaint when families are saying something seriously wrong or the MMSE begins to show issues, or when there's care complications, people needing to make changes. We want to see that shifted. Now, when I use the word empowerment model, what exactly does that mean? Is that just a term that we have created? Absolutely not. So healthcare patient empowerment models have been longstanding and substantiated in research over and over and over again. We see them in cancer programs, we see them in diabetes, we see them in Down syndrome. So empowerment models are not attached to diseases that are easily mitigated. They're attached to all kinds of diseases, but they have certain pillars that mark them as empowerment. And these are the four most common pillars. So knowledge and health literacy, that people are making conscious decisions. They know what can help. They are empowered with the knowledge that allows them to participate in shared decision-making with their doctor. They're not relying on somebody to say what we should do, but they're assimilating that information, that they acknowledge and understand their own personal control. And that's something that can very easily feel like it disappears in a dementia, and that is personal control. Well, it doesn't. There's a lot of things that we lose control over in this life, with or without dementia. But there's a lot of things we hang on to. And then finally, positive patient-provider interaction, which means honesty, which means understanding what kind of information is important to share and making sure that's an open dialogue and that people are heard. So this is where we want to get people to, that we're incorporating early stage sensitive screening tools, and that really dementia evaluations occur in primary care. Primary care is the discipline where most of us have the most trust. They know us in a full way in terms of our health status. And in uncomplicated dementia, completely possible to occur in primary care. There are many, many primary care providers completely able, willing, interested in, and capable of thorough dementia evaluations. And really looking in those middle stages, integration of screening tools that can help us detect when complications begin to occur rather than waiting till crisis. And we see when we begin early on preparing people, we see a more active, proactive, conscious, what I would consider meaningful and perspective, completely based on the philosophy of the individual at end of life. Now, let me say this, and I'm gonna wrap up quickly, and so that there's some questions. How in the world do you know if you're empowered? So, say you're a person with the disease, say you're a family member, are you getting this right? Do you have the tools that you need? How do we see it? How do we assess what empowerment looks like in someone with the disease or their family member? Number one, it's individuals that are open about telling others. When people are ashamed and keep it to themselves, we've got some emotional processing to do. When they're part of planning with their family rather than resisting. That dialogue needs to happen together. When there is a perspective, when people begin to see, gosh, life is not over. It isn't my choice. This isn't what I wanted, but I'm going to choose to live with it. So when we begin to see that kind of perspective emerging, we know we're headed in the right direction. When there's wellness actions, when exercise is at play, when we're dealing with depression, when we're socially engaged, all those kind of what we consider the pillars of wellness. The concept of relinquishing and replacing, that it's not just giving up. So what if I can't drive now? Maybe it's figuring out how I can get from point A to point B. Maybe it's developing a plan so that I don't get isolated. But this concept of if I have to give up something, what do I replace it with to ensure that quality of life exists? And again, this honest exchange with providers. It isn't quizzing oneself and practicing, dementia tests, or not telling providers when we have depression that there's some honesty at play. And, we can see empowerment features even in middle stage dementia and beyond. And that translates in terms of caregiver confidence and in terms of acceptance of help. Those individuals who put their foot down, say, I'm going to do it myself, tend to be the least empowered. Depression management, both from the side of the individual with the disease and the care partner. Clarity and risk benefit assessment, that there is no perfect decisions here. You're not going to make them for your loved one. Your loved one isn't going to make perfect decisions and maybe never has. We certainly never have, most of us in our life, made all the right decisions. Your doctor may not make perfect decisions. That the decisions that have to be made are this risk benefit profile, the pros and the cons, and there'll be some of each in this process and what's best for us as individuals and the person diagnosed. Caregiver ongoing learning. We can only learn bits, I think, at times. It doesn't make sense to me to study up on end stage when you're in early stage and there's years and years in between. It just doesn't make sense because we don't know exactly what that would be. So really taking that learning in doses but being an ongoing learner. And then family inclusion in research. Not only are there research opportunities for individuals with the disease, there's research opportunities for family members. So, we've done surveys of our services with those patients and families we've served, and those results tend to be high. Same with providers when we add to this interdisciplinary approach. So how does life get better for someone with the dementia? It's having people around that don't run away from hearing concerns. You can express concerns. This isn't easy. That doesn't mean that you're weak. It doesn't mean you're giving up. In fact, quite the opposite. Ability for some prediction and planning, and that goes back to early detection, that we do the best when we can anticipate and plan for so that we don't feel lost or overwhelmed. We professionals that not only understand what someone needs, but who they are, because lots of what someone needs is actually based on who they are as a person. And the disillusion of hopelessness. Anybody hopeless out there? I'm telling you, let that go. There's hope abounding. There's lots going on in science. There's lots we can do as a community, including fighting stigma and patterns of care that do not make sense. We need to understand what we have, what we have in our control, which is a lot of stuff. So before I wrap up and take any questions, CCN programs are many. We do individual consultations, both here in the clinic with those patients and families our neurologists see. We go out to primary care practices for the CCN. So those 81 providers, we make rounds in those clinics. And we meet with people in the general community that have questions. We have support groups, both Zoom and live, and some of which are disease specific, some of which are population specific. We have early stage support groups. We have support groups for caregivers of individuals with Lewy body, caregivers of individuals with FTD, and we have general caregiver groups. We have an activity program on Zoom. So if you have patients or if you have family members that are more in the middle stage, we have a Zoom activity program they can participate in. We partner with Church of the Resurrection for a walking club, and that will begin again in the fall. It's on hiatus right now. We have a program that has been on hiatus for COVID the last couple of years called Minds in Motion, which is a partnership with Nelson Art Gallery. And so the docents have been trained there, and they do dementia-friendly tours that are free to individuals diagnosed and their families. It is not stage specific. Couples can go, adult children and someone diagnosed can go, grandchildren can go. It's a wonderful program. And we have a flyer on that. There's tours coming up. We have education programs of all sorts. We have advocacy opportunities like the Experience League and Pairs, which really the advocates here are those with mild cognitive impairment and early dementias. They are the stars of those shows. They have the most important voice in the room. And then we're beginning new programs in the fall. One I'm very excited about called Hands on Deck, which is supported volunteer opportunities in the community. What I hope you take away from this conversation is that early detection is important. What I hope you take away is that interdisciplinary team approach is very important. That there's not one discipline that's going to have all the answers. There just is lots of perspectives that can be meaningful. So whether that be the providers, whether that be the social work navigators, but also programs like physical therapy, occupational therapy, people that are in programs like Rock Steady, and the Big and Loud programs, et cetera. All of those things are wonderful. We really need that village. And then collectively moving to a place of community. So when we talk about expanding the team, it's not just individuals diagnosed, it's not just families, but it's also friends. It's also neighborhoods. It's also faith communities and other social outlets that we all need to be aware, not just that there are people in our midst that have cognitive changes, we know that, but we also need to be aware there are ways that we can support each other in staying in this life and staying in this community. That people do not have to step back. So those are real important to consider and think about. If there are questions or extended dialogue, you can certainly let me know, and my contact information is on the screen. We have about 2 minutes, and I want to leave some time for questions. So there's a question in the chat about how do people with families get started in this program with the Cognitive Care Network. Simply, you can just call myself. There are other team members that we can get you connected to, but the number on the screen would suffice for today. So it is simply a call. Other questions, thoughts?
Michelle, I know that you had presented last week for the with Dr. Burns, and I think that you had mentioned a question was asked about some individuals that you had mentioned a question, and I'm trying to think of the language that was used in the question, but you didn't feel that you were able to address the whole question. It would now be a good time to address that question.
Yes, and so let me take that one, and let me take also the one in chat. So let me get to both of those questions real quick. So in the chat, the question, are people who haven't been diagnosed but are having concerns able to start an evaluation? We are certainly able to have a conversation with you. Sometimes people do not know where to go or how to get started. And so absolutely, if there's that kind of question, you are free to call us. The question that Dr. Ladowski is mentioning is about are people with intellectual and developmental disabilities higher risk for Alzheimer's disease? And the answer is yes, if they have Down syndrome. The answer is there's a higher prevalence, even if they don't have Down syndrome, but they have other IDD like autism. And how that would be pertinent in terms of this dialogue is back to that early detection, that sometimes there are special populations who might be even more unlikely to be picked up in early stage. So it is Really important to know what the indicators might be. If you are a loved one or if you know of someone who is caring for an adult that has an intellectual or developmental disability, we have a special education program called Being Proactive. In fact, is coming up, I think, June 24th here in the Fairway, on the Fairway campus, and might be something good to get connected to.
Thanks, Michelle.
Thank you very much, everyone.
All right, any other questions?
Thank you.
All right, Michelle, thank you so much. We appreciate the your time today and all of this really great information that you've shared for us. Always a delight to hear from you, so thank you. We're going to go on ahead and wrap up for today. Again, thank you for that outstanding presentation, Michelle. As a reminder, we will have our weekly webinar presentation next Thursday at 2 p.m. So keep an eye out for that information in your My Alliance Monday email, or you can go to our website at kualzheimers.org. This presentation recording will be available on our YouTube channel shortly, which you can find by navigating to our website under weekly webinars or using the link in the reminder email. If you have any questions or comments in the meantime, feel free to email us at myalliance@kumc.edu. I hope to see everyone next week. Thank you and have a great rest of your week.